more you have repetition and hit with some of the high yield stuff, the better. So this one should feel a lot like, yep, I got that one, yep, we did it, and yep, I've heard that a whole bunch of times. So that's kind of where, how you should feel about this. And then we'll hit ortho at the very end. So kind of a separate little lecture of that. The only thing that I want to draw your attention to on here, and just a plug as you're about to go into your rotations, is even if you really hate taking care of pediatrics, or I have not convinced you that there's anything exciting at all about pediatric pathology over the last 3 months that we've been together, I would encourage you, if there is ever a time in your rotations where you can get certified in PALS, that you do, to just get that experience with smaller equipment, with smaller patients, with weight-based dosing. So if that's offered anywhere, just take advantage of it, whether or not you're ever going to use it again. It can be helpful. So we aren't going to talk about PALS. It is not part specific of your PANCE, other than the parts that we talked about, like adenosine, synchronous cardioversion for SVT, some of that kind of stuff. Okay, so that was very loud, so sorry about that. One of the things that we're looking at is epidemiologic data that shows what things are we concerned about as a community of pediatricians, and what sort of things are we imparting to you. So the way that we determine that is what is causing that morbidity and mortality. So we talked a lot about morbidity, haven't talked a lot about the mortality aspect. And so the emergency and trauma area is where that really comes into play. So if you are doing this by the numbers, less than a year, you are thinking, likely this child has some sort of developmental, some sort of genetic, some sort of inborn error of metabolism, something wrong that happened embryologically or in utero that is causing their death. So under a year, that's what you're thinking about. When you go from then 1 to 14, the most common cause of that is some sort of accident, some sort of unintentional injury, motor vehicle accidents, something like that. The reason that I bring this up particularly is that up until 2021, we would have said that from 1 year all the way up to age 24, your number one cause of mortality was always accidents and unintentional injuries. After COVID, the data switched, and so in 2021, now your most common cause of mortality, of death, in the teenage and young population is now suicide, homicide, so a firearm injury resulting in death. Why is that particularly important? Well, that determines what our education or risk stratification is, how we're screening people, and particularly, that's the highest hitting population that we are going to do. So the adolescent clinic, young soldiers, young airmen, young Marines, young sailors, all the different people that we are seeing, their highest likelihood of dying is from suicide or homicide. So that data switch should make all of us be like, whoa, that's what's going on? Yes, big data switch there. Don't spend any time memorizing this. It is just to show you some of that. It actually has the old data. This is from 2020. So it does not reflect that it is suicide, homicide for that age group. But just when you're looking at really who is, and what age groups, and how many are we talking about of kids that are dying? We don't hear about a lot of kids dying. The ones that do are typically falling into these categories. Inside that highest category, so your highest category of accidents and unintentional injuries, that's where PEDS trauma then starts taking over. So you think car accidents, you think ATV accidents, you think anything where there is that unintentional injury or high velocity accident is resulting in this PEDS trauma. So that's what that is showing. Particularly motor vehicle accidents. So all of these things in a row should tell you why you have certain pediatricians, we're looking at this one, myself included, there are some things that we give recommendations on, and then there's some things that we stomp our feet and jump up and down on and really try to get you guys and families on board with, such as the back to sleep campaign or co-sleeping or any of those things. Not because we just think it's a good idea, but because we're going off of the data for what is killing children. So that's how we're determining what we're educating, what we're jumping up and down corn screaming about is based on this mortality data. So your acute care, same exact thing. Doesn't matter. For all humans, anytime you're doing that primary assessment, Your ABCs are going to be first, your primary survey, your secondary survey, so you're doing all of the same things that you are going to be doing for that adult, you're doing for the kid as well. The one that I want to point out, because there are slight differences here, is when you're looking at initiate therapy based on achievable goals and endpoints. The developing brain does not do well with prolonged hypoxia. Okay? So most of your CPR incidences are going to start respiratory and end up cardiac, that's how it's going. And most of the time, after a couple of minutes, the developing brain has little to no chance of surviving that anoxic brain injury. A lot of times then, your therapy or your endpoint for a CPR or a resuscitation that you know is going to end poorly or result in the pronunciation of this child being dead. You will notice if you're in a hospital that pediatric codes go significantly longer, whereas it might have been called much earlier in the adult world. Why do we do that? Number one, study after study has shown that a parent or a caregiver that is there at the time of the pronunciation of a child does much better with the grief process than if they don't. So if there is some instance, an accident or something that happens and the parent is not there, many times the endpoint is we are going to continue this code and the CPR until this parent can get there to be able to connect those dots so that they are able to process and grieve. So that's one big difference in when you're talking about therapy and achievable endpoints or goals for a pediatric trauma or acute care resuscitation event. That is a little bit different than you might see in the adult population. Your primary assessment is always going to then be the same, taking into account that this child has particularly large heads, so you should have an extra ounce of caution with that C-spine and any of those precautions. The other one that I will add, so I usually put breathing in bold because not only their airway and breathing is likely the cause of that. I add a second C for circulation, where I put the central nervous system as well, because we're trying to protect that little developing brain of theirs, and everything else is still the same exact as the adult world. A couple of things then, the airway differences here, so the airway placement is different. If you have a neonate, do you remember what position you are putting that neonate in for block 1? So that big head. So sniffing position, but what else you're having to do because their head is so big? Yeah, something under their shoulders, because you have to raise that so that your airway is not kinked. We already talked about a bunch of the breathing things. Do you want to tell you anything else here? I do not. If you see GCS, so that was some of the questions that I was getting. How do you do a GCS on a kiddo that cannot talk to you, that cannot respond to you like an adult can? So there is a GCS, a Glasgow Coma scale, that is modified for your infant who cannot talk or walk yet. So your eye opening is still the exact same. Your verbal and motor is where things are different. So now your verbal, rather than speaking to command, is for the infant is about their cry. So are they cooing, are they crying, then still responsive to pain. So a little bit different for that verbal, and then the same thing with your motor. If they can't walk, it has been adapted for whatever their stage is as an infant. So still going to be ultimately the same scale. So what is the number at which you intubate? Less than 8, intubate, yep. So that's still the same, and just how you get there is a little bit different for an infant. Your labs that you're going to consider are all going to be the same thing. The one that I would add is I have a lower threshold for a kiddo in a traumatic event to get a type N cross. So what's the difference between a type N screen and a type N cross? Yep, when we're crossing, we're saying, I want this blood ready to go. I just don't want to know what's out there, and what we got, and what this kid might be compatible with. Get me this blood so it's right here, ready to go. So that would be the one thing that I would add for a cross match. Same radiology that you're going to consider. Any chest X-ray, portable chest X-ray you can do for an adult, you can do for a kid. And then in those traumatic instances, always remembering that a lot of blood can be collected in the abdomen and pelvis. So a lot of times those traumas, you're getting chest, abdomen, and pelvis. Same for kids. Same exact thing. I put this one in here because now that we are completed with PEDS after this, and you are completed with phase 1, the words that when you hear somebody say these words for whatever system you are in, the central nervous system, respiratory, cardio, or skin, if you hear these, this patient is sick. So this is where you should be by now, is word pattern recognition, that if you're trying to describe a sick patient or a sick kid, and you're trying to describe, or you hear this, or you see these words on a test, they are trying to tell you that the patient is sick or the patient is toxic. Okay, so these are all your buzzwords for that. So just a reminder that this is where you should kind of be as far as your medical speak going into phase 2. For your resuscitation, you will have a very low threshold to make sure that this child has supplemental oxygen. So when in doubt, go ahead and give them that oxygen. It's much easier than not. You're also, same for the pediatric patient and the adult, your crystalloids, your sodium, your NS and your LY, are going to be very similar in that process there. Low threshold if you need to give blood products, PRBCs, and then we'll talk about the different types of shock in a little bit. Big difference then for peds versus adults is most of the time their cardio compromise is secondary to their respiratory compromise. So that is the order of events that happen most of the time. Do you remember how that changes for BLS then in a child? Yep, your rate of compressions to breath is different. And what else? You initiate CPR super early, and then there's also the one where you do the round of CPR before if it is unwitnessed. So lots of differences with a kid, because if you can correct respiratory, you can keep them out of the cardiovascular event. It's not likely that they're having a heart attack, a STEMI, any of those types of things. So fixing their respiratory early is going to be paramount to keeping these kids alive. The stats suck. So if you look at that, 6% are going to survive and out of hospital, and 27 survive cardiopulmonary in hospital, right? So the stats are absolutely abysmal if that child gets to the point where it's no longer respiratory and it's actually cardiovascular. So everything in our power to intervene early with respiratory is why, because once you get to that point, it's functionally a point of no return. So that respiratory failure, if you're thinking about this from a physiologic standpoint, you can either have not enough oxygen or too much carbon dioxide. So hypoxia or hypercarbia, either one of those things. Your common causes being common, do you remember what we talked specifically the physiology with air trapping? Which one of those is that? Asthma, yep. So asthma, the air gets in and it cannot get out. So that's a true hypercarbia one. All the other pathologies, still the same, bronchiolitis being that one in those infants under 1. So as a reminder, if we're going with hypoxia, so something is happening where either they're not able to get the oxygen molecules there, so they do not have enough oxygen. So you have a ventilation perfusion mismatch, meaning that you cannot, the perfusion is going right by and you cannot get that oxygen into that bloodstream. For this, the body's compensatory mechanism will say, let's breathe faster and pump quicker. Let's just try to get it through more often. You'll come in often with cyanosis and this altered mental status. You're comparing that to hypercarbia, where now you can't have that ventilatory response. You have too much CO2, so it is in there and it just cannot get out, as opposed to being on the outside, it cannot get in. You have this often increased dead space ventilation, an increased minute ventilation here. Asthma was that perfect example. And this one you will often see this altered mental status early. So when you're in the ER, you will hear things about children with this air trapping. So you'll hear, I think I told you this in block 2, they got tuckered out, they just got real tired, and their diaphragm did not get tired. Their CO2 rose. That is what happened. That is what is causing the altered mental status, and that respiratory depression. Diaphragm did not get tired. Your ABCs are your treatment: supplemental oxygen, early ventilation. So give me one of those. Has anyone ever sat in a CPAP or a BiPAP? Sat in a BiPAP? How comfortable is that? It's terrible. Now picture doing that on a 3-year-old who has asthma. How well is that going to be, right? So if you're thinking about what kind of ventilatory assistance you are going to give this child, making sure, are they developmentally appropriate? Is this going to be something that is going to be beneficial, or are they going to rip this off their face? And if they rip this off their face, maybe that's a good sign that they're not as sick as I thought they were. So we get a lot of feedback from this. If you have a 3-year-old who cannot breathe very well and has no problem with you putting a BiPAP on them, are they sick or not sick? They are very sick. If they're like, oh my gosh, thank you. Sat in a BiPAP machine for 20 minutes in residency once, and I was like, I thought I was seeing the light. Like, I was like, this is like the push-pull, very scary. But if you work with respiratory therapy and you have the chance, have them put you in a BiPAP so that you understand what that feels like for a patient. Really more helpful. Okay, the different types of shock. So you will need to know the different types of shock to be able to pull this out if I give you a scenario with a child. So as a reminder again, we'll talk in detail about hypovolemia, most common type, distributive, might be second most common, cardiogenic and obstructive, much less common in children, and then everyone's favorite for boards, the dissociative type of shock. So it depends on what is going on and how this presents. So one of my pet peeves back in middle block 1 or early block 2 is when people use shock and sepsis synonymously. They are not the same things. You can be septic and not be in shock. Sepsis can lead to a type of shock. Do you remember which type? Distributive, yep. But sepsis and shock, not the same things. So make sure you use your words correctly with that. Most common type, hypovolemic. So a couple of things that people will often forget about. Children are losing so much because they are just breathing more rapidly and they have a large surface to volume ratio, so they lose fluids very quickly. So when they have things like diarrheal illness or acute AGEs, or they have significant burns, they are at risk much earlier for a hypovolemic shock than an adult is going to. So something to be aware of, they have that, but all of your shock of the tachycardia, tachypnea, and then the signs of that poor circulation are going to happen very, very early in a child. So a low threshold to replace volume as needed. I think I was talking to somebody about how do you replace that volume. I think I put a hidden slide in here about that, how to calculate that. Your distributive shock, you guys were right on the money. So in this, you have adequate volume, it is not distributed to the correct areas. So the perfect example of this is something such as an endotoxin from some septic event has caused this to dilate in the periphery. It is now distributed out to the periphery and it cannot get back into your central core. So most common there with sepsis. This also happens with anaphylaxis. So anaphylaxis is the one that people forget goes with distributive shock. You start with that warm. As you progress, it becomes more cool. As everything is more stagnant, has less perfusion and circulation. And then certainly, if you have the rest of the signs that go with sepsis, a worse form of that distributive shock. Probably one of the least common types in children, unless you know that they already have some type of congenital heart disease. So if the question stems, or if there's something in real life and they don't tell you right up front, I am a tetralogy of Fallot pathology, I have a hypoplastic left heart, whatever it is, it's probably unlikely that it is cardiogenic shock. Not to say it cannot be, but more unlikely. They will have to, in a test, give you some sort of indication that there is something wrong with this heart, or there is some significant metabolic derangement for that. With this, you see those same types of shock, but you just see that the pump itself is not working. Contrast this to your obstructive shock. So now it might not be that the pump is not working, but the pump has nowhere to move. So a tamponade is that classic physiology of this, where the heart could beat just fine, but it is stuck. So something is not allowing it to continue to move. Do I have a tension pneumothorax that's in the way of my heart? Do I have a tamponade in the pericardial sac that is obstructing this? Do I have a tumor that is in the way that my heart cannot move? So the obstructive portion versus the pump itself in cardiogenic shock. And then last but not least, this is the one that boards love so much because it is the easiest one to test in a way, and you will get it confused with infectious processes. So when they are saying what is being replaced where that oxygen molecule on your hemoglobin is supposed to sit. So the carbon monoxide goes and sits there rather than oxygen, that's not going to be great. It will bind, it has trouble unbinding. So you get that dissociation there. Methemoglobinemia is the other one that you will see. same thing, tachycardia and tachypnea. They'll often come in groups. So if you have this, the classic board presentation is everybody that lives in the household, or everyone in the dorms, or a whole barracks full of young recruits, something like that. They all come in, and what does their skin look like? Cherry red, yep. So that's what you are looking for that. So, and then they're asking you what type of shock, so dissociative shock. Make sure you can distinguish that. If I give you a scenario of a child, which type of shock they are in. Early recognition is key because children will compensate, and they'll compensate really well until they don't. So recognizing anything earlier is going to be super helpful for kids. And there's that fine balance, right? If we fluid resuscitate too much for cardiogenic shock, we've just made it really bad. If we don't fluid resuscitate enough for hypovolemic shock, that's also really bad. So we're trying to manage how much fluid with the type that they have, how much respiratory support and oxygen do they actually need, and then can their kidneys hang. So cardiovascular, pulmonary, and renal are your three systems to think about and to manage simultaneously for any of the three or any of the five types of shock. This was the question that we asked yesterday. I'm not going to hold you responsible for this. This is not one of the things, but if you were looking at how do we know how much to replace, it is based on your kilograms of weight. There's a daily fluid amount, and then how much they need to run per hour to calculate the fluid deficit, how much they are going to continue to have ongoing losses, and then what's their regular routine maintenance. So don't worry about this unless you're very curious about how to calculate that deficit, but that is how you do it. So I'm not going to ask you to calculate on this test. I wrote it last night. It's not on. For all of your same stuff, this is the same as adults, so just a reminder of that when you're looking at that. Your vital signs are vital, they're not optional signs, so make sure that you have a low threshold to look at a heart rate, to look at a respiratory rate, a blood pressure, because they are vital signs. Your CAP refill. Where is going to be the best place if you're checking that on a child who has itty bitty tiny hands? Yep, and somewhere where you have more surface area. So instead of looking at their teeny tiny little fingernails, the back of the hand, the palm of the hand, the bottom of the foot is going to be able to give you a good assessment. You are pushing, moving that blood out of the way. That can be one thing. Mental status certainly, and then your renal output, trying to have 1 per kilo per hour. A couple of things then that we're looking at when we're doing PEDS trauma then. So we already said that that was a huge cause of childhood mortality. So if that's the most common cause, then what's the most common within the most common? So head trauma is going to be the most common cause. So this could be from an MVA, this could be from child abuse, could be from any of those types of things. The other thing then you will see that sometimes is a spinal cord injury. And they have this big head that is significantly larger than the rest of their body. So that can cause, have a higher propensity for those spinal cord injuries. Some of these, and just to be aware of, you can have an entity where they look like they have a spinal cord injury. It looks like a nerve pattern, and yet you cannot see any of that pattern on radiograph. That is called then skiwara, where you have a true spinal cord injury that doesn't correlate with the radiograph finding. So skiwara is an entity that you see in kids just to kind of be aware of for that. Can show you on MRI, so that would be one of those indications to truly get an MRI of this patient if your clinical exam truly is not matching what the x-ray of your skin is. Your abdominal, oh wow, okay, so I don't know how to spell things apparently, and so that should say second, not 2RD. And so then down below it should say third, not then 3ND. So those should be switched. The correct second is up top, third is down below. Must have had a little bit of a stroke, so sorry. So abdominal is next. There's those big toe bellies that you can see. Remember, there's a lot of blood that can be held in the abdominal cavity. So something to be aware of there. Then thoracic trauma is next. Remember, if you ever see anything posterior rib fractures, that should be child abuse until otherwise confirmed. Your most common one though, however, is going to be your splenic injury. So if you had to pick something The one that is going to pull a lot of blood and be significantly a hemodynamic concern for these kids is any kind of splenic injury. So as a reminder, left upper quadrant, we can transfer and have radiating pain up to that left shoulder, the Kerr sign. And you often see this in a kid that is in a motor vehicle accident that has the belt across them, or most common way I've seen it on any kind of board exam is they're riding their bicycle and they came in and flipped over the handlebars. So the handlebars came right in, over the top they go, resulting in a splenic injury. So if you see a kid flipped over on the bike, you're like, I know what they're going to ask me, it's a splenic injury. You try to not operate on these kids. We want to keep the spleen. Why do we want to keep the spleen? What does it get for us? Encapsulated bacteria, I heard it. What are those encapsulated bacteria? Strep? H. flu? Klebsiella? Yeah, thanks. And what other one? Yep, the Neisseria. Yep, those are your encapsulated ones. Those are big bad infections if you get those. If we had to take the spleen out because it has a splenic trauma, now you are asplenic. What did we give those sickle cell kids that were asplenic for prophylaxis? Hydroxyurea, but not for prophylaxis for infections. Penicillin. Yep. So if we take the spleen out of anybody, if they're asplenic, any kind of kid, we're going to have to prophylax it. The same as if they were asplenic from sickle cell. Same stuff. Liver injury. The issue with this is that it has that dual blood supply. Remember what their dual blood supply for the liver is way back in freshman year? Yeah. So your portal vein and then your hepatic artery. Yep, so you have this dual blood supply. So one is feeding the liver, one is going to get detoxified. So that's a lot of blood in that liver. So if that is injured, that's another big area that you have a lot of collection of blood. So again, trying to have the non-operative management, but knowing that you can have hemodynamic compromise early in a kid with a liver injury. Renal injuries are a little bit different. Ideally, these are well protected in the back. However, kids in general have less of a fatty structure around the kidneys than adults. So a little bit of a higher risk of having an injury with that same amount of force for a kid versus an adult. You'll often see this on UA if there is bleeding then because you will see blood in the UA. One of the things you see there, we try to always avoid the pancreas, and the body is pretty good at protecting the pancreas in the kid as well. So we'll always check what's more specific, an amylase or a lipase. Lipase, perhaps. So if the pancreas is involved, make sure you get a lipase to see if it is. And then any kind of intestinal injury, you're worried about perforation. So anything we talked about from that last lecture, worried, is there going to be bacteria on the inside? Do I have a pneumoperitoneum? What's going on with this? Okay, this takes us then to the brew. And the brew, it's just ridiculous. So let me tell you a story. When I was in residency, does anyone know what a brew used to be called? It used to be called an ALTE. So ALTE. It was an apparent life-threatening event, right? And so you're like, something happened. We don't know what it was. The kid's totally back to baseline, and you're discharged. You get to go home, right? So your diagnosis was apparent life-threatening event, and your plan of care was discharge home, right? That doesn't match particularly well. So rather than figure out really what is causing that more, because we still don't have that answer, we just changed the name of what it is. So an ALTE is now called a brew. It's not a brewy, it's a brew. Okay? A brew is the dumbest name ever because you're like, it describes nothing. It's a brief, resolved, unexplained event. Right? Dumbest name ever to me, I think. This doesn't tell me anything. This means something happened, freaked the family out, freaked the parents out, freaked the child out potentially, freaked the docs out, freaked the PAs out, and the kid's totally back to normal. We have no idea what happened. That is an entity that happens with children. So something unexpected happened. Everyone is frightened by this, and usually there is some sort of color change. So this can come in all shapes and sizes. So this could be a child all of a sudden every limb, every muscle tenses. It looks almost like a seizure activity. This could mean that the child went completely limp. This could mean a choking, gagging episode. This could mean that they had an episode where they quit breathing and turned blue. So this can look like anything. It is something that is brief, resolved. We have no idea why. That's what a functional brew is. Bleeding, thought with some of this, and one of the things to evaluate is that do they have that GERD? So it's more than that physiologic GERD. Do they really have true GERD, just causing a laryngeospasm, the choking, gagging, color change with feeds? So that is going to be one of those things. Seizures can be another one. Any kind of traumatic event, so child abuse could be on that list as well. And then the other thought is this something that is pointing us towards an inborn error of metabolism that we haven't been able to pick up on yet? So something going on. Or is this a start? Is this the presentation of a big, bad, serious infection? So can be anything, and most of the time it is nothing. So all of your diagnosis is most of the time based on history. So you see this more in premature infants. You see this more in where there's recurrent illness, certainly where there's any kind of trauma. Most of your physical exam, you have a normal baby by the time they get to you. So they've come by ambulance or they've come by POV, they are there now. And certainly you're looking at that full head to toe exam for any abnormalities, particularly neurologic, but most of the time, by the time they get to you, they look completely normal. This then, your evaluation is indicated by history. So this is not a blanket, do this for everybody in an ER or a clinical setting. But if you think, well, maybe they're hypoglycemic, maybe they weren't feeding well, they've been sick recently, let's get a glucose. Remember, you're never going to be faulted for getting a glucose. Low threshold for electrolytes and glucose. Is there a glucocytosis? So do I want a CBC to maybe check for any kind of infectious indicators? There are blood gas analysis, if you have that. Is there anything with that acid-base status that could be going on? A chest x-ray, if there's any lingering respiratory symptoms. If not, don't get it. And then any kind of more advanced imaging, if they really have something on video, give you a story, has focal signs, something that is not there. However, if that's the case and it's still lingering, you don't have a brew because you don't have the R part. It is not resolved. So by definition, it needs to be brief, resolved, and not have an explanation for it. Can't do any of the infectious workup, further workup for any kind of GERD could be reasonable to do there. And then this is the big question. Do you have completely freaked out parents that look like they need Xanax for themselves? You might need to say, hey, we're going to admit overnight to watch this child, even if they've completely returned to normal. Or is the parent comfortable and this is their 7th kid and this has happened before, they just wanted to make sure and they can discharge home. So that's going to be the big provider brain conversation with your patient, with what the patient in front of you looks like, and what that risk stratification is. So, but there's an OBS unit, we can leave watching for 12 to 24 hours, that's ideal. So then the question is, okay, well, how brief is brief? So brief means about under a minute. If you're prolonged more than about a minute, you're really no longer brief. So about 60 seconds is where we're going. And then under a year. So under a minute, under a year, completely returned back to baseline, and then we don't have a good explanation for it is the true word. Drowning I also have a problem with. Right? So the definition of the way that we talk about drowning, we call it whether you die or not drowning. So it's either fatal or non-fatal. I don't understand why it is not called drowning and you're drowning. You didn't ask me. So drowning happens either way, it's fatal or non-fatal. So something has gone awry here. You know what drowning is. But you have something that triggers your laryngeospasm to protect your airway. That can only be maintained for so long before it opens up. Now you have drowned. What happens there is what we kind of talked about. Surfactant can be denatured pretty easily. So anything that is getting into that alveoli internal portion, you can denature your surfactant. You can do this. Do you remember from block 1, what else can denature surfactant in a young neonate? Meconium. Yep. So meconium could cause that and cause meconium aspiration syndrome. So functionally, that child is drowning from meconium. This is that same similar process. We're now drowning from having liquid that goes and denatures your surfactant. So whether or not that's fatal or not, depends on time and the significance of the hypoxia. Boys are 4 times more likely than girls. Why do you think that is? Yeah, bigger risk takers, impulsivity. I heard someone say they're dumb. They're just hyper, just adventurous, right? Your resuscitation is going to be always your ABCs, your C-spine precautions, certainly always if it is unwitnessed. and then oxygenating as much as you can. You are not dead until you are warm and dead, so you're heating up patients if they are hypothermic, and then these patients, these kiddos will go to the ICU for this. Certainly this should make sense to you. You have a better or a worse prognostic indicator, so you are less likely to survive a drowning episode as a child if you have had CPR more than 25 minutes, if your GCS is less than 5, which means you are by definition intubated, which means that you are not back by the time you get to the hospital, so CPR is ongoing, fixed and dilated pupil, certainly if there's any seizures, or if they got you back, you got ROSC, and 3 days later you were still out, much worse prognosis for a child for that. So that was my very first week of residency, my very first patient. On July 1st, that day was a family that had gone to Schlitterbahn and the kid had gotten sucked under the wave pool. First patient out of the gate of residency was a drowning patient. So he met all of these criteria. And my computer is dead. So I think that means that it doesn't want to talk to me. Oh, that's back. I don't know what's happening. It wanted me to stop. Well, are you guys okay if we just continue with one side for a little bit? Press through. Okay. A couple of words on some burns as a reminder. Kids love to burn themselves. They love it so much. If a kid can find something to burn themselves on, they will. They want to touch hot things. They want to find a way to burn themselves. That's great. This can cause death in a significant number of young children because of the fluid loss and infection risks. So burns are something that we think about often. How deep is it? How expansive is it? Where is it? And then other associated injuries. Always think about this. Remember, your skin tries to keep the good stuff in, all of your immune system and your water, and it tries to keep all the bad stuff, the infection, and the outside world out. Things that your skin does if you were a child, significance in part of the immune system. So any of those things that release cytokines, any of those basic immune processes are happening in the skin. So when you have compromised that, you have compromised your immune system. Nice little animation of reminder if you are superficial, all the way to the partial thickness, then the full thickness, and finally if you are down into that bone structure, muscle and bone structure, you are in that full thickness or 4th degree burn. Your 1st degree burns, the classic example of that is what? Is a sunburn. Do babies get sunburned? Yes, they do. How old are you supposed to, when can you use sunscreen? Anyone know? On a baby. Birth, 6 months. Yeah, so good guess. So 6 months is when you can use sunscreen. Between 6 months and a year, you use baby sunscreen, then specific. And then over a year, you can use regular old sunscreen for a kiddo. So under 6 months, you just keep them covered. And so a lot of times, that's when we'll see is young babies that will get sunburns because their skin is very, very sensitive to the sun. And oftentimes they're not using sunscreen because they're not supposed to be. I grew up in New Mexico. The sun is very, very hot and very, very close to the sun. And so families are just out, babies can get sunburned. So this first type, this 1st degree or the superficial burn, epidermis only, leaves no scarring, that classic business. Your partial thickness, these ones are very painful, but again, they do not scar because you are in that epidermis and part of the upper portion of that dermis. So it usually heals well again, no scarring for these kids. So this is super helpful when you're determining this in the ER in a clinic type setting because that's always the family's question, is this going to scar? Your deep partial thickness is technically also that 2nd degree, much lower, does have blistering, and you do have dermal involvement. Some modeling, a lot less painful because you have a lot more nerves that are involved, and it functionally looks like a full thickness burn. Often will scar and will need some grafting. Anytime that you are seeing and it looks like it is wet, you know it is a deeper burn. This is a good example of that superficial secondary burn. This child found something they wanted to grab hold of. You can see that it is that because it follows that pattern. The flexural creases are maintained, so that makes it seem like it is much more of an accident than the child abuse that we talked about. It's got that blistering, so you know that you are more than a superficial, that you are in a little bit of a deeper. Now it is opening up. It looks really bad, but then at the end there is no scarring. So now you're at a superficial second degree or a partial thickness second degree. Then your full thickness, where it's going all the way through. Certainly when it's involving any of those deeper tissues, you are well past any kind of primary care management and you are at a burn unit. So the things that you need to know then as a primary care PA, where is my nearest NICU? Where is my nearest burn center? Where is my nearest pediatric burn center? Right? So we are next to a burn center. Where's our nearest burn center here? FAMC. Where's our nearest PEDS burn center? Not FAMC. No, not University. Dallas. Dallas is our nearest pediatric burn center. Okay? So being aware wherever you are stationed, where's my NICU, where's my nearest ER, burn center, PEDS burn center, will be really, really helpful because you will need those. Very sad picture of a 3rd degree and then a 4th degree. Burn's a really cool unit if you get the chance to go work on there as well. Your inhalation injuries should always be things that you think the boards will love this. They love to talk about this because of those secondary edematous side effects that you see later. So particularly in children who have that kind of precarious airway, if you have any concern for any kind of inhalation injury, make sure you have control of that airway. And not the superficial, you need subglottic airway control of this. So they will usually let you know this. So the way I see it the most is singed nasal hairs, there's smoke in the face, that voice change. So any of those should make you think inhalation injury immediately. You need to control that airway. Your very first thing is going to be intubate those kids, because once you have too much edema, it's really, really hard to recover from that. For your burns, please don't memorize this. Please do not memorize your rule of 9s. I'm not going to have you calculate how much of a child is burned. My point of this, and the takeaway of that, is that their heads are really big. So you have to count more for their head than the rest of an adult. So the adults, where it's all your rule of 9s, you have a lot for that abdomen in a child and a lot for that head. So that's where most of their mass is. So burns that affect them there are significantly more of that percentage. Your treatment then, if it's inhalation, is airway control. Certainly, if there's any kind of that smoke inhalation, giving them that early supplemental oxygen, making sure you're calculating for how much loss they have had of fluids and replacing that and continuing IV fluids. Again, I'm not going to have you do deficit for fluids, but making sure it's by kilo and that you're accounting for what they've lost, what they're predicted to lose, and what their daily maintenance need is. You have to think of the 3 parts to be able to calculate what their daily need is. Trying to prevent that heat loss, so preventing hypothermia is imperative, and then you definitely want good wound care. So if you are managing this as an outpatient, which most of them will be, because I grabbed a curling iron, I crouched the stove, I poured ramen on myself, something like that. You're managing those with a couple of things. So first, making sure the wound is clean, making sure that they have good pain control. So Tylenol, Motrin, what was our dose of Tylenol? 10 to 15 mg per kg for Tylenol. What was Motrin? 5 to 10, yep, 5 to 10 mg per kg for Motrin. So you're making sure they have good pain control. And then their dressing changes, and then if you are doing any prescribing medications, your first thing is going to be your Silvadine or your sulfazidine. That is really good for any kind of burns. And one place you won't use this for, because it stains, is face. So you don't use Silvadine on the face for kiddos. You can also use any or a topical antibiotic like a Neosporin ointment as well. When to transfer to the burn unit, if you think that you need to, burn centers are super great to have phone consults with. They'll do video conferences with, so if you're like, ooh, I don't know, unless I know that I have this percentage-wise of a full thickness burn, I know that it is a circumferential burn, I know it is somewhere hands, feet, genitalia, face, an electrical burn, a chemical burn, if I know what it is, but otherwise, these are great people to consult. Super, super helpful. The burn unit here is awesome with CMC. Burn unit in Dallas is really good too. And this is a good place to stop, so let's stop here and we will finish up our last lecture tomorrow, and I will work with